Okay, everybody, it's 8 o'clock. Good to see you all in person and online. This is our last grand rounds of the year. Hope you've had a good year with these. I've certainly learned a lot. So we'll be getting back together with grand rounds again in early September. Ariana will be sending out a notice today with the schedule for next year, so keep an eye out for that. This morning we have Dr. Christine Neeb, who's an associate professor in our division. She went to college at Middlebury and med school at University of Rochester and did residency in family medicine at University of Illinois, and then obtained certification in addiction medicine through the practice pathway. She is an expert in addiction medicine, and very happy to have her back again today, speaking about issues with benzodiazepines and sedative hypnotics, dependence, and use disorders with each of those. So grateful to have you here, Dr. Neeb. Thanks for joining us. Looking forward to your talk.
All right, thank you. Okay. So today we're just going to talk about a lot on benzodiazepine dependence and a little bit on use disorder. So ideally, my goal here is that people will be more comfortable with the tapering principles of for benzodiazepines, identifying dependence versus a use disorder, just feeling a little bit more comfortable talking to your patients and figuring out who really needs to be tapered and who might be able to stay on these medications. So I always like to go back to the history of benzodiazepines because I think it's important to remember why we have so many patients on them. And it is frankly our fault as physicians. We put patients on these, maybe not us, but our predecessors. Especially back in the 1950s, these drugs were marketed particularly toward women for almost any type of physical or psychiatric issue. Milprem, this advertisement right here, was actually a combination of meprobamate, which was an anxiolytic, plus conjugated estrogens during menopause. So they were just recommended to be on these every single day. And the medications like meprobamate were then followed by fluordiazepam epoxide, diazepam, alprazolam, and then zolpidem. And each of these medications were seen to be more safe, and we seem to never learn our lesson. They are not more safe, and we have just continued to prescribe and prescribe. So thinking back to our pharmacology, if we're thinking about benzodiazepines, like why did we think that benzodiazepines were somehow more safe than barbiturates? And technically they are. So benzodiazepines are indirect GABA agonists. They are going to cause that GABA channel to open and close faster and faster, depending on how much benzodiazepine you give. And that's going to increase the chloride channel opening and decrease neuronal excitability. And if you think about it, the most decreased neuronal excitability you can get is an overdose. And then if you take all that away, you can get a seizure. Barbiturates, on the other hand, they just increase the duration of the chloride channel opening. And so in that way, like they are less safe because you can just keep that channel open and just continue to decrease neuronal excitability. Whereas with benzos, there is going to be a ceiling effect as to how frequently you can open and close that channel. So in the past few decades, and this is a little bit older data, but we have been prescribing benzodiazepines more and more in primary care, essentially doubling it from 2003 to 2015. And despite us kind of thinking as benzos as a misused prescription, the vast majority of people in the United States who are using benzodiazepines are doing so as prescribed, particularly adults in our like 50 to 60s range, which is often when we're trying to start to talk to them about the risks of these and think about tapering. So why do we put people on them at all? So there are anxiolytic effects. They're just really short term. So if you look at initially when we start people on benzodiazepines, there's about an 8-point difference on the Hamilton scale, and that just starts to extinguish over time. So at a point at about 12 weeks, there's no difference between benzodiazepine versus no benzodiazepine. Z-drugs, I think sometimes we think of these medications as not the same as benzodiazepines, which is a marketing ploy on the part of the pharmaceutical company. They just bind to a specific component of the GABA receptor, but they do the exact same thing as a benzodiazepine. They have a quicker onset of action, they have a shorter duration of action, but very similar adverse events and even some additional adverse events that we don't think about as much with regular benzos, like sleep driving, sleep walking, sleep eating, those kinds of things. Similar to benzos, they do work a little bit at first. They actually only improve sleep onset by about 22 minutes. And they reduce the slow wave sleep, which is important for our memory consolidation and growth. And then by 3 months, again, that effect is extinguished and there's no difference between being on the medication and not. So what are the bad effects? If those were technically our therapeutic effects, a lot of them. So I won't go through all of them, but there's about a 70 to 80% increase in motor vehicle accidents. There is a significant increase in falls, particularly in the elderly. This can worsen anxiety, worsen memory, increase risk of dementia. So lots and lots of reasons to try to not start these in the first place, and for many patients to try to taper them if possible. They come in lots and lots of different names, and sometimes, like if you do have a patient who is misusing them, they can sometimes get them off the dark web. So just be aware that there might even be some that are not listed on here. And then one of the ones that's interesting, so carisoprodol, that is what we usually use as a muscle relaxer, but important to note that one of the metabolites of that one is a benzodiazepine. So we want to think of it similar in a similar way, especially if you're thinking about combining with benzodiazepine with opioids. So why alprazolam? It seems that our patients really, really want alprazolam, and there's actually a lot of reasons why. So it ends up being the most prescribed benzo, despite not really being any better than any other benzos, and it ends up being disproportionately prescribed to at-risk patients. So what does it do? It actually has very rapid absorption, so patients get a rush, like they have that feeling of anxiety, they take a pill, and they almost immediately feel better. So that's very reinforcing to the patient. Low lipophilicity. So it lasts just a short amount of time in your body, and patients are ready for that next dose by the 6 to 8 hour mark. They're watching the clock. They want the next dose of benzodiazepine. Very short half-life, which means that they're going to have more severe withdrawal and more complicated rebound. Again, basically telling the patient that they need this medication. It's the least sedating. So for patients who want to function throughout the day, being on alprazolam actually makes that more possible rather than something like diazepam or lorazepam that might be a little bit more sedating. Has a very high potency, as we know, like often like the highest dose of alprazolam is going to be a 2 milligram pill. And then it has some unique dopaminergic and serotonergic effects. So when patients say they feel different on alprazolam than any other benzo, they're actually telling you the truth. And we need to think about that when we're figuring out how to taper them off of this. So why should we not deprescribe? It really comes down to the withdrawal symptoms. So and it depends on the study that we look at, but anywhere between 15 to 44% of patients on chronic benzos are going to get moderate to severe withdrawal when they discontinue after only 3 to 6 weeks of being on benzos. So that's a lot, and you don't have to be on the benzodiazepine very long to start to experience this. If patients have been on it for a long time, like more than 6 months, at least 40% are going to have moderate to severe withdrawal and 60% mild withdrawal. And then there is a phenomenon that we'll talk about in a little bit, but there's this protracted withdrawal symptom that was first kind of described by Heather Ashton back in the 1980s, 1990s. And this lasts months and even years, and about 10 to 15% of people are thought to experience this. So what does it feel like? I think most of us know it's pretty similar to alcohol withdrawal syndrome, but it does have some unique parts to it. So of course, the anxiety and anxiety-related symptoms, which of course make patients think that that's why they need it, because a lot of times they're getting a rebound of the symptom that they were prescribed it for in the first place. So tremor, sleep disturbances, appetite issues, sweating, dysphoric feelings, all of those will happen. Perceptual disturbances, these are pretty unique to benzos. So hypersensitivity to any stimuli, creepy crawly sensations, depersonalization feelings can be very upsetting to patients. And this particularly happens like when patients are tapered off high doses. The major events, I think, are what we worry about the most, of course, but these are the least likely to happen, particularly if we taper them off slowly. So seizures and precipitation of psychosis and worsening of depression, suicidality. So this study came out of actually University of Colorado here. So Dr. Ritvo is one of our addiction psychiatrists. And this study looked at a little over 1,200 people. They were self-selected because this were people who were on a health and wellness website. And they were did a survey of these patients who had come off of benzodiazepines, I think in the past year. And about 85% of patients in this study reported some type of withdrawal symptom from coming off of benzodiazepines. And then of those, more than half had experienced these symptoms for a year or longer. So it's pretty significant. Again, these are patients who went to this website and of course were like searching for answers on this. But this is kind of, they are trying to describe this phenomenon that Heather Ashton described a little bit in the 80s. And the new terminology that we're trying to use is benzodiazepine-induced neurologic dysfunction, and really trying to figure out what is happening to these patients because they're actually developing symptoms that were completely distinct from the symptoms that they were prescribed the benzo for in the first place. So who is more likely to have severe acute withdrawal? So patients who are on higher doses of benzos, patients who use oral, it's relatively rare for most of our patients to be injecting them. Patients who are on there for a longer period of time, those ones with a shorter half-life like alprazolam, the more rapidly we taper them. And then patients who have the higher pretreatment anxiety and depression symptoms and other and substance use disorders. So this study came out at the end of 2023 and kind of threw a wrench into what a lot of us used to think about the risks and benefits of tapering patients off of benzos. So this came out of the VA. It was a retrospective cohort study, and they looked at over 300,000 patients, just a chart review. Patients who had been discontinued off of benzodiazepines who had been on them long term. And what they found was that patients who were discontinued actually had an increase in mortality and other potential harms versus patients who were just continued on the benzos. And this actually held true for patients who were co-prescribed opioids, which was a big thing. So we used to think, oh, let's just take these patients off of them because we know they're dangerous. But now this is telling us, well, you might actually be doing harm just by taking them off. Now, this was just a chart review. We don't know why the patients were taken off. We don't know how quickly they were tapered. Were these patients higher risk to begin with? And is that what's happening? It's just kind of some information that we really need to think about and investigate a bit more. So after hearing all that, you're like, well, let's just keep them on it. That sounds easier and it sounds terrible to come off of them. But why should we consider deprescribing? So we know that there's actually a reduction in anxiety when we take patients off of these medications. Their psychomotor function improves, cognitive function improves. I put asterisks next to our old study that said we thought we would reduce all-cause mortality. Again, that might not be true anymore. We want to keep these medications out of the community. We want to reduce risk of falls, lots and lots of reasons to try to get patients off of them. And ideally, we want to taper them before the patient is has an emergency or has many risk factors or there's a bad outcome, because that's when we can do it more slowly. So this was the study that we used to consider to tell us basically that there was an increase in all-cause mortality if patients were on benzos and that we should take them off. But really, this study looked at patients who had never been on benzos versus those who are on long-term benzos. And in that situation, like, yes, there is an increase in all-cause mortality, both with and without opioid use. But really, this isn't telling us that the patient is going to go back to that risk level when we taper them off. The thought now is that these patients are going to be kind of in a risk category all of their own once they've been on them. But ideally, we just don't start patients on long-term benzos. So there is a pretty well-known risk of dementia and other cognitive dysfunction in patients who are on long-term benzodiazepines. This meta-analysis was done, I think, back in 2017. And the relative risk is about 1.2 for patients for risk of developing dementia. And the longer patients are on them, and being on longer acting benzos puts patients at higher risk. So particularly patients we want to worry about, those over the age of 65, patients who are prescribed more than one benzo, or they're prescribed a benzo plus a Z drug together. They're being co-prescribed opioids and gabapentin. They have a history of falls. They have a high fall risk, COPD, substance use disorder. They have a history of overdose, or they're planning pregnant or planning to become pregnant. So at least all the top ones of this seem to be all of our patients who are on benzodiazepines, at least in our primary care practices. So why would we not want to deprescribe, or maybe we want to delay it? Of course, if patients are taking benzos for seizure prevention, and that if it is specifically like a neurologist or you are saying they need this for seizure prevention, not that they have a seizure disorder and are also on a benzo. In that case, we just want to be more careful about taking them off of it. Patients who are end of life, of course, these have great uses in palliative medicine, and we don't need to take patients off of them if they have a limited life expectancy. And then in general, the harms of stopping can outweigh the risks, the harms of continuing. So I find this particularly in my patients with severe mental illness. So if they have a history of psychosis and we've tried to take them off of it and it precipitates a worsening of psychosis, in those patients, I'm often just continuing them. But these are going to be a pretty limited number of patients that we really, really want to avoid deprescribing. So first thing we're going to do, if we have a patient that we think probably should come off of them or they would be a good candidate, is really utilizing a shared decision-making model. We really don't want to force a patient on an involuntary taper if we don't absolutely have to. It does not go well, and it's rarely successful. So ideally, we want to use our motivational interviewing skills and talk to the patient generally multiple times. This is going to be a multiple visit plan that's going to be developed. Chances are you're not going to convince the patient to taper off their benzodiazepines the very first time you're talking to them about the risks of this. I often like to address the underlying illness before tapering. So if they were started on it for anxiety and they're not on any SSRI, we want to talk to them about that, probably get them into therapy, get them up onto a therapeutic dose of that SSRI. If it's for sleep, we need to start addressing their lifestyle issues, so sleep hygiene, exercise, diet, all of those things, maybe CBTI if that's something that that is available to them, all before we even start to decrease the medication. So it can be really hard, right, trying to convince patients that this medication is not helping them anymore because they are very attached to it. This is often their only coping mechanism for anxiety or insomnia, and they're very used to having immediate gratification to help their anxiety. So they feel that feeling, they take a pill, they feel a new feeling, and then the cycle just continues and continues. We also have to really explain to patients that just because you stop the medication, your anxiety gets worse. That's not your anxiety coming back. That's actually a symptom of benzo withdrawal. And with time, a lot of patients can start to understand this, but it's not something that just happens overnight. So once you talk to your patient many, many times, they're on board. Now what are you going to do? Because as we talked about, we don't want them to get benzodiazepine-induced neurologic dysfunction. We don't want them to be super uncomfortable. So we're going to establish a baseline benzo dose and try to address the interdose withdrawal. So that interdose withdrawal is often going to happen with those shorter acting medications like alprazolam. So it only lasts 6 to 8 hours and the patients are starting to like spike their withdrawal symptoms throughout the day. So generally we want to talk to the patient, find out exactly how much they're taking. A lot of our patients actually might not be taking the full amount that you're prescribing them, and they might have an entire stash of medication somewhere. We don't want to accidentally increase the amount that they're already taking. So get a good history, find out how much they're on, and then we often, so then that'll be our starting point. And we'll talk about for some of the shorter acting ones, and if they're having interdose withdrawal, we might transition them from that shorter acting to a longer acting because we want it to stop being that they're taking this medication for anxiety or insomnia and that they have a stable amount of medication in their body at all times. So they're not experiencing withdrawal, and then we're slowly tapering it down in a way that their body is not really going to react to. And unfortunately, there's not an easy transition like with opioids. This is like an approximate equivalency, and I usually go on the more conservative side and then potentially go up if I if I underestimated how much they need. But it's unfortunately not a perfect conversion. So in general, when we're tapering, we want to consider a few different principles. Like one, we want the patient to be able to have input into their taper. That doesn't mean that they're going to just be able to be on the same dose forever. But if the patient is having a really hard time that week, that month, we want to let them have some say in this. And we want to make sure we start with really small reductions. So I want to get the patient on board. The very first time I taper the patient, I make a reduction, it's less than 5%. I want the patient to be surprised at how easy it is and surprised that they're not feeling anxiety, not feeling insomnia. And so that's usually 5% or less, whatever the smallest amount is. And we want to make sure that we're reducing by a percentage rather than by a fixed amount each time. Because if we do a fixed amount, like 1 milligram per month, 2 milligrams per month, that's actually going to end up in an increasingly larger reduction in the GABA occupancy, and they're going to have more side effects. Once we get started, usually it's about 5 to 10% reduction per month tends to be the best tolerated, and those actual amounts are going to get smaller and smaller and smaller as the taper progresses. And I often have to tell patients at the end of it, because they want to be done with it, that they just need to stay the course, because if they just stop it all of a sudden, then they'll get those withdrawal symptoms. So it's going to take a long time, right? I often tell my patients, this is a marathon, not a sprint. Completely discontinuing the medication is going to take 12 to 18 months or longer. I always try to tell my patients, do not skip doses. Don't try to be a hero. Just take this exactly as I'm prescribing it. I also like to avoid the PRN doses, because to me, I'm telling my patient, you need this sometimes, and I'm just taking it away from you. I want them to get out of that habit of thinking like that and be working with their therapist or working with me on developing some other coping skills for whatever those symptoms are. And then a lot of times they just need a lot of reassurance. If they're having withdrawal symptoms, they can be weird, they can be upsetting. We just want to reassure patients that we believe them, that this is part of the process, and we can adjust if this is too uncomfortable. I'll say I've been here for a year now, and I think I have one patient that's on the very last step of tapering a benzo, so a full year to get the patients off of them. And I think she was only on something very small, like 1 milligram of lorazepam to begin with. So it takes a long time. So the cut and hold technique, this is the one that I use the most. And this is just percentage of the current dose is taken away, and then we just hold the dose until the symptoms subside. I usually go longer than the symptoms take to subside, because we're in primary care. I can't see them every week, every 2 weeks. I usually see them about once a month. This can be done really easily I usually use diazepam tablets, because those have a much lower potency. They come in doses as low as 2 milligrams of diazepam, so you can cut those in half, and some patients are even comfortable cutting them in quarters, so you can kind of navigate that reduction. Sometimes as you get down to those really low doses, it can be too much of a reduction and you have to kind of change course. But for most patients, a diazepam taper using those 2 milligram tablets is pretty doable. The micro taper, so you might have patients coming to you actually requesting this, because it's all over Reddit. And it is evidence-based, it's just challenging to do. So this is you would take whatever dose reduction you were going to do in a month. So say that was 10%, and then you'd actually divide up that amount into a daily micro reduction, which is usually a microgram in size. It's really hard to do. So, I mean, you have to have a patient who is able to usually weigh out that amount of medication, or you have to have it from a compounding pharmacy. They'd have to have droppers. We do have some patients who want to do this. Again, a lot of health literacy. Sometimes we'll do the cut and hold first until you get down to the very, very end. And if they're not tolerating it, maybe we'll have to do a micro taper for the last little bit. But just be aware, this is out there. You don't have to do it, but patients might come to you with this. The Ashton protocol is kind of the original evidence-based benzodiazepine reduction method. So Heather Ashton was a professor in the UK back in the 80s and 90s, and she came out with a lot of information on benzodiazepine withdrawal, on protracted withdrawal, and then a lot of these, what she called schedules, which show exactly how to reduce the patient's benzodiazepine dose. And it specifically switches patients from those shorter acting benzodiazepines to longer acting benzodiazepines over time. And that's really helpful because, like we said, some patients will say, like alprazolam works differently than any other medication. In this way, like you're not doing an abrupt switch, it's over several weeks. A little bit of alprazolam is replaced with diazepam over time until eventually they're completely taken off of it. Again, very labor intensive. There's lots and lots of other schedules. This is a high dose alprazolam switching over to diazepam. There's ones for clonazepam, for lorazepam, all sorts, other doses. But this is labor intensive, but patients actually generally like it because they can see the schedule online. They know what's coming. I think the hardest part of this is probably getting insurance to pay for both types of benzodiazepines at the same time, which is not impossible, but sometimes it does require some footwork. So how do we make those tiny reductions? My go-to is usually the diazepam. It's just the easiest to do. There are oral liquids that you can dilute. There are compounded prescriptions that go through a compounding pharmacy. You can get precision scales. There's tapering strips from the Netherlands, which unfortunately we don't have here. As you can see, a lot of these are off-label, so you want to, work with your pharmacist because it can be harder to get these prescribed if they're not aware of what you're doing. And so as we can see, the diazepam tends to be the one that comes in the tablets with the lowest potency. So those tablets are readily available. Other medications can be harder to taper off of, so like temazepam, the lowest dose it comes in is 7.5 milligrams. That's going to be a little bit harder. And then the Z drugs, honestly, are pretty hard to get people off of because the lowest dose they have is often like one of the therapeutic doses, like 5 milligrams of zolpidem. So what do we not want to do? We don't want to do the 25% reduction per week method. This was done in my residency all the time. We thought we were being kind to people. Really, it just increases the risk of acute withdrawal, protracted withdrawal, and it's unlikely to be successful. It's very likely to get your patient off of your panel if that is your goal, but they are just going to be somewhere else getting benzodiazepines. And then the skip dose method. So this is often, we let patients kind of decide. We say, okay, well, you're getting 90 per month. We're going to give you 89, 88. Really, this is kind of ignoring the big issue here, right? Which is not that the patient has anxiety. The issue is the patient is now dependent on this medication. So when we do that, we're basically telling the patient, you can decide when you withdraw. And what's going to end up happening is they're just going to run out at the end of the month and then go into severe withdrawal at the end of the month and then show up to you miserable, upset, in withdrawal, and it's not going to work. I put this up again because I think it's super, super important. We need to figure out why they were started on that benzo in the first place and make sure that that is being addressed. I think a lot of us will see this where patients are on benzodiazepine and no SSRI in the history, no counseling. So we just really need to make sure that we are doing something about that. Otherwise, we're taking away the only coping mechanism they have, and it's going to be really hard for them. So once you're doing this, sometimes, I'll do the check-ins with patients and just ask them how they did. The initial work of this is going to be right at the beginning, those first several visits or the preparatory visits. Once they're on a benzo taper, these are like 5-10 minute visits. They can just be done via telehealth. They're really easy because patients get comfortable with it. They know what questions you're going to ask. They're like, yep, it went fine. It felt uncomfortable for a couple days. Maybe I had some sleep problems and then it went away, ready for the next reduction. Or they might tell you know what, like the holidays are coming up. This time of year is very hard for me. Can we, just pause this month? And I often let the patients pause during a stressful time. But if they do come in saying that they're having withdrawal symptoms or anxiety, it can be really hard to tell the difference. And you want to know because you want to know if you are going too fast on your taper or is that underlying anxiety not treated appropriately. And so there are a lot of symptoms that are common to both anxiety and benzo withdrawal. So panic attacks, depression, dysphoria, insomnia, all of those things. The ones that are very specific to benzo withdrawal, we want to ask about because that's going to help us out. So that depersonalization feeling, the skin crawling feeling, hallucinations, muscle twitching, altered sensation feelings, psychotic symptoms. Of course, that would be like a much more severe if you went very fast. But this can kind of help us figure out, like, do we just need to take a step back or pause for a little bit? Or, do we need to really, do we need to adjust that SSRI or try a different medication, do more counseling? Some patients might need some medications to help them as we're tapering. So we call these like adjunct medications. The one that actually has some of the best evidence is just melatonin for sleep, getting patients on that good sleep schedule. PRN hydroxyzine has some evidence behind it, pregabalin. Buspirone on its own does not, but interestingly, buspirone plus imipramine does. I usually go with gabapentin and pregabalin if they're having withdrawal symptoms or a lot of anxiety, withdrawal symptom kind of overlap. Valproic acid and carbamazepine, they're on there technically. I've never used them because those seem like pretty big guns, and really the evidence behind them is just that they can increase abstinence at 5 weeks post-taper, and the studies were done back in the 90s when the tapers were done a lot more quickly. So the vast majority of the patients that we are managing are going to just have dependence, but I feel like a lot of us are very worried that we actually are managing a use disorder. And I think it should hopefully be reassuring that most of the time, it's just dependence. It's just going to be a long taper. In order to tell the difference, so all of the use disorders follow the same criteria for DSM-5. You just insert the different substance. So if we think about someone with a use disorder, they're using larger amounts or for longer than intended. Not the case with our patients who have dependence. They're taking exactly the amount that we're prescribing. They're usually not asking for more, not asking for less, not using it all up before their next appointment. Having persistent attempts or unsuccessful efforts to cut down. Again, most of our patients don't want to stop. They haven't even thought about stopping, and so that doesn't really apply to them. Spending a great deal of time getting the medication, using it, recovering from it. Again, it's pretty easy for them to just go to the pharmacy. And if they're not misusing it, then they're not going out and getting it from friends or family. So that doesn't really apply. Cravings or a strong desire to use. Again, our patients are just taking them for the symptoms that they were prescribed for, or they have dependence, which is different. So it doesn't apply to them. All of the lifestyle issues, so like recurrent use resulting in failure at work or school, having social problems, giving up recreational activities. Patients actually feel like the benzos help them with these things as opposed to harming them. Using in physically hazardous situations, this can be a little bit tricky sometimes because we might see them as having a side effect that's physically hazardous. But if they aren't seeing that, then we don't really count that in the DSM-5. That would be more like getting a DUI or something. We would count that in alcohol use disorder. And then the continuing use despite physical harms, again, similar. If a patient has cirrhosis from alcohol use disorder, like that's pretty obvious. We know that most patients understand that alcohol causes liver disease. Patients are going to have a lot harder time understanding like the nuances of rebound insomnia. And so if they're not quite understanding that, then we don't really count it. And then tolerance and withdrawal, that's just normal human being that's just normal human physiology. And so that we only count that toward DSM-5 criteria for a use disorder if they're meeting other criteria. So if you do find someone who has a use disorder, it's not just dependence. Honestly, it's going to be hard to manage in the primary care setting, just because by definition, these patients cannot control their use, right? So we can't give them a month's supply of benzodiazepine and just expect them to be able to taper off of it. That's not realistic. So often these patients are going to need to be sent to someone with to either outpatient or addiction medicine, or sometimes even inpatient addiction medicine to do a residential taper. Yeah, I mean, a lot of that is just because patients are just going to have unlimited access to benzos. In my outpatient practice, sometimes I'll do one day at a time to the pharmacy, and the patient will have to go every single day and pick it up. It's a lot of work. But even when I do that, if they have completely uncontrolled use, they're going to be able to get more somewhere else. So just to be aware, You don't have to manage use disorder in your practice. Really, we're focusing on trying to do deprescribing for dependence. If you do want to manage a use disorder, one of the important things that I use as a tool is urine drug screening. So I use the mass spec kind, the confirmation kind, because I want to know exactly which benzodiazepine they have in their urine, because I'm going to usually be prescribing diazepam, which doesn't have a huge street value, and patients are often going to be using alprazolam or clonazepam instead. And I want to know, do they have that in addition to what I'm prescribing? And then that might tell me like, hey, like you're not actually doing well on this outpatient taper. Maybe you need to go to a higher level of care and do residential or inpatient treatment. For patients that you're just deprescribing for dependence, you can do your normal once a year urine drug screen, unless there's some red flag that comes up. So I was just going to go on to a few cases, and we'll see if there's people here or online who can jump in with some ideas. But so these are just kind of, I think, cases that we all see all the time, right? So new patient visit, they come in, they're establishing care and they need refills. And of course, one of their refills that they need is alprazolam. This person is just 42 years old. She has a history of hypertension, insomnia, and anxiety, and is just prescribed amlodipine and alprazolam 1 milligram twice a day. She's been taking it for years. And you see on the PDMP that she's been getting regular refills from one provider and does not get any other controlled substances. So I was going to throw this out to the audience and see, how do you guys manage these patients? So
This is Mindy. So I probably would ask her what she's taken in the past for her anxiety. Has she ever been on, something like an SSRI, and why they chose to use alprazolam twice a day rather than a different maintenance medication.
Who's refilling it? It's Friday, it's 4:30. Want to go home? Okay, yeah, honestly, like a lot of us are going to refill it, right? And I totally agree with people are saying, like, let's talk to her about, SSRIs, about other ways to manage this. So there's a lot of right answers to what to do here, right? So like we can definitely refill the medication. We can discuss the risks and possibility of a taper at a future visit. You can talk about your practice and, make sure that she understands like, hey, like this is not something that I normally would prescribe long-term. If you're okay with that, then, I'm happy to take you on my panel. You can also, like, if you are more conservative, you don't have to refill it until you get the previous records. Like maybe you want to make sure that there were no issues at her previous physician's office. Maybe you want to get a tox screen first. Or you could potentially give a short-term refill. Like, we don't have to give a 30-day supply. We just say, I want to get your records. I want to get a tox screen. So I'm going to give you a 7-day supply. And then once I get all those back, we can talk more about doing long-term. So then the cases get more uncomfortable, right? So this is actually a case, I think it was a Cherry Creek case that was sent to me. So this 76-year-old woman had past medical history of anxiety that's been well controlled with therapy, and she established care about a year ago and is on long-term benzos. She'd previously been on up to 4 milligrams of clonazepam per day. 2 years ago, she was on 1.5 milligrams per day plus 1 milligram as needed, so she came down a little bit. She's continuing to take 1 milligram clonazepam per day now. 5 years ago, she had a vertebral fracture, and she now uses a cane to ambulate. She's very nervous about tapering off clonazepam, and she's very active with work and traveling. She does not want the taper to interrupt her life. She sees a therapist who strongly recommended against a rapid taper due to the risk of post-acute withdrawal symptoms, and suggested that she ask you about a liquid clonazepam titration, so the Reddit menu. She drinks 2 glasses of wine 2 or 3 days per week, no other substance use. She does not take opioids, and her only medication is amlodipine for hypertension. So how do people feel about this patient? I'm not in. It's 5 o'clock on Friday. I've gone home. So yeah, so you could definitely consult me. That is an option for sure. This was actually a case where someone consulted me for them. But right, like we're getting more uncomfortable. She's not in her 40s anymore. She's has multiple risk factors, right? So she didn't have a fall from the benzos because we actually got a very good history on this vertebral fracture, but now she doesn't ambulate well. And so she's at risk for falls. She's over 65. She drinks a couple glasses of wine. So like, this is where we're kind of getting like, well, I really want you to get off this medication soon. I don't want it to be an emergency where I'm getting you off this medication. At the same time, she also has come down on the medication quite a bit over the past few years. So she's not completely opposed to coming off of it. So this is someone where, you know, you're kind of stuck in the middle here because you don't necessarily want to do an involuntary taper, and have a bad relationship with that patient or have that patient leave and just go somewhere else and keep getting the medication. But, you know, you do want to keep her safe. So options here, yeah, just continuing those risk benefit discussions and continuing the regimen for now. This patient, I think, is going to get there eventually once she has a little bit more trust in like the medical system in general. You could do the micro tapering if that's what she wants to do, and she has the health literacy to do it. I think that's an option. You could involuntary taper her. That wouldn't be my choice, but I don't think it would be wrong given the number of risk factors that she has. And then one of the things we did talk to her about was this, stopping alcohol use, which is like a relatively easy, if they don't have an alcohol use disorder, risk factor that you can eliminate. And she was fine with that. And as of right now, she is still on the clonazepam and we're just continuing discussions. And I think she's eventually going to get there to want to do a taper or be willing. Then case 3, this was actually a case from back when I was in Illinois. So 82-year-old woman with hypertension, diabetes, CAD, cognitive impairment, anxiety, coming in for a new patient visit and hospital follow-up, which are always fun. 3 months ago, she had a subdural hematoma from a fall at home. She went to a sniff until a week prior when she left AMA because she didn't like the facility. She lives at home alone. Her daughter checks on her once a week, and she's been taking a 0.5 milligram of clonazepam 3 times a day for several decades. Not on any other meds for anxiety, and her other meds include amlodipine, hydrochlorothiazide, atorva, gabapentin, and quetiapine. So this is the case, right, where you're like, you cannot do this, right? I mean, this gives me anxiety just looking at it. But this patient, of course, like has already had a serious adverse effect from the benzo, right? A fall causing subdural hematoma. She is in her 80s. She lives alone. She doesn't have anyone watching her. She's on 2 other medications that are sedating. So like, this is just kind of like a no-go here. So this was a situation where like I absolutely would and did involuntary taper her. Unfortunately, that's just not good medicine to keep a patient like this on a benzodiazepine. If she had live-in support or if she had been in the SNF, which I talked to her about, I could have done it slower, but that was just, she did not want to do that. And of course, like I tapered her and then she never saw me again, which is unfortunate. But ideally, we want to be getting to these patients when they're at case 1 or when they're at case 2. We don't want them to get to case 3 because then we just don't have many options left. So some of our resources that we have available. So I'm available to help with these tapers. I can help if there's unclear whether it's dependence or use disorder, if the patient wants and you want them to have a really in-depth discussion about it. You want me to help with the taper, and then you can send me a message to our pool, IM Shoots Addiction Scheduling, or you just send me a message and I can get it there. We also have a pharmacist who can assist with the HOPT clinics, Dr. Mansour. He's actually looking for business with this. So if you have a patient who wants to do a taper, you just send him a staff message via Epic and he can get your patient on there and can help with that. That is it. Questions for me?
So this, to me, it's such a big change. Someone's on a
Yeah, for alprazolam, I generally just change them to a longer acting drug because it's so short acting and you're going to get so much interdose withdrawal. And then it's such a high potency drug that's just really too hard to get down to those smaller doses. So 4 milligrams of alprazolam, usually it's a 1 to 10 to switch them over to diazepam. So I would probably be doing 10 milligrams every 6 hours of diazepam. And then you can start to take away, you think 4 milligrams of diazepam would be 10%. So then you can I often tell them, like, when do you want to do the reductions? And they'll be like, oh, like maybe I'll do the morning and afternoon dose. And then they'll be doing 8 milligrams, 10 milligrams, 8 milligrams, 10 milligrams. And it takes a long time. And then, each time you do it, it's a percent. So it's going to be a little bit less in terms of milligrams on the taper. But yeah, or if they're having a hard time with the switch over, you could do the Ashton protocol and do a gradual switch from the alprazolam to diazepam. Yes, so it's a risk benefit. So I think it's what diazepam is metabolized by the liver. The ones outside the liver, those ones are, so oxazepam, temazepam, lorazepam are not metabolized by the liver. So yeah, so if you have a patient who, particularly like if they have renal disease or they have hepatic dysfunction, you might want to take that into account. But still in general, you want to find some type of longer acting medication. And like if there isn't an option, you might just want to be on the more conservative side when you do that equivalency switch over, so that you don't end up having you don't end up having it build up too much in their system.
Compounding pharmacies or the compounding pharmacies that you reach out to?
Oh, sorry. Someone asked about compounding pharmacies and if there's any that I reach out to. I honestly have not had this happen yet here. All the patients have been okay with doing the diazepam tablets, but yeah, it's a good question. When it comes up, I will keep an eye on it and let you guys know. Sorry. Yeah, so you're not going to, so the question was, how do you convince a patient to do a taper? Again, that has to do with the shared decision making. You're not going to convince anyone to do a taper, especially on the first visit. This is really going to be someone who you have a relationship with over many visits. And it requires a lot of discussion. It requires a lot of motivational interviewing, having them like if they're coming to you with, hey, I'm having difficulties with sleep. Okay, well, you're on this benzo. Let's talk about how this is affecting your sleep. It does take a long time. And often I try to tell them, like, listen, like, as long as there's no like major safety issue, I say, like, just because we start on this route doesn't mean that you are married to it. You don't have to go to zero. We could just start trying it. And if this is terrible, we can stop. And sometimes that is like reassuring to the patient, like, okay, like you're not going to just like make me keep going down this road, even though I'm really uncomfortable. Sometimes you can get a little bit of buy-in that way.
How much? 18 hours to do the system. How much of that is dependent related to sleep or alcohol?
Yeah. So the question was about patients who are just using benzodiazepines for sleep. So for instance, like 2 milligrams of alprazolam at night. And so yes, those patients are not going to be experiencing the interdose withdrawal that we're talking about. And that might be someone who, like, you don't necessarily have to switch over to a long acting. You could just start to taper away a little bit of a time of that alprazolam. And they probably are not like having, like we're talking about, interdose withdrawal. It's all about just their sleep rebound that they're having.
So I guess I have some small things with that. So obviously, if you are on alprazolam, one of the shortest acting drugs, you want to longer acting benzodiazepine. If somebody's on lorazepam, it seems that or clonazepam, it seems that are you switching them to diazepam too, or are you saying, well, those are longer acting?
Yeah. As long as they're doing okay and not having interdose withdrawal, you can really taper them off of any of the medications. I am because I've done managed so many patients with use disorders. My habit is just to switch them over because clonazepam has a high street value. But you don't have to. You can definitely start to taper them off of the clonazepam. And as long as they're tapering those small dose reductions, then you can just continue to do it. Those are still a little bit higher potency, so you can sometimes get like smaller decreases if you go to the diazepam, but totally fine if you want to stick with what they're already on and do those little reductions. I do, but that's just my preference. That's not like evidence. There's not like a paper that says it's better.
Question about efficiency on and how do you prioritize
the question was yeah, how do you prioritize for patients who are co-prescribed benzos and opioids? I just let the patient choose. Just let them be in charge of it because either one is going to be a risk reduction, and a lot of them have very strong feelings about which one is more important to them. Interestingly, a lot of them will choose the opioid because they are more attached to the benzo.
Benzo too. Mm-hmm. I'll give you the example before we started. Sometimes patients who are 80 years old and 15 old and they can't keep it out. And that sounds dangerous. So if you were to try to take it out and switching them to that.
Yeah, the question was about zolpidem and how to get patients off of that because yeah, like we saw the smallest dose of the zolpidem is 5 milligrams. So yeah, you can try to taper them off of the zolpidem by cutting those medications in half and seeing if you can do that. Again, those are big reductions. And sometimes I do switch them over to a longer acting benzo, but it's the Z drugs are really, really hard. Yeah, unfortunately, you're not getting the interdose withdrawal, but they need a lot of reassurance that like their sleep is eventually going to get better because it's going to be very uncomfortable when they're starting to do that. All right, thank you.